Hi, my name is Jessica Shackman, and I'll be talking today about avoiding an airway disaster, managing tracheostomy emergencies in the ED. I have nothing to disclose. So why do we need to talk about this today? Isn't this something that ENT or general surgery or even respiratory therapy should be managing? And how often do we see patients like this anyway? Well, nearly a quarter of all ICU patients will require a tracheostomy for prolonged respiratory support. And when these patients come into the ED, they can decompensate quickly and become a true airway disaster. So let's dive right in. A patient comes into your ER with a chief complaint of problem with tracheostomy. Go see the patient. Don't procrastinate on this one. Eyeball them, get a set of vitals, and decide within the first few minutes whether you have a potential airway emergency on your hands. There are essentially three pieces of information you should obtain in your history within the first few minutes of seeing your patient. First, when was the tracheostomy placed? A surgical tract takes about 7 days to mature, and an immature tract can make your airway management much more complicated. 2, why does the patient have a trach? This essentially tells us our chances of a successful oral intubation if it comes to that. And 3, what kind and size of trach does your patient have? Send someone in your department to find the closest match that you can to what the patient has, as well as a size or two smaller. Let's briefly review some relevant anatomy. The trachea begins well below the cricoid cartilage, so your typical trach is going to be placed much lower than a typical cric. The blood supply is composed of several major blood vessels, the most important of which is this innominate artery, otherwise known as the brachiocephalic trunk, which sits just below the trach stoma and crosses from left to right. Standard tracheostomy equipment includes an outer cannula with or without an inflatable cuff, an inner cannula here which sits inside the outer cannula, and the obturator, which is a solid piece that goes inside the outer cannula and is used only when inserting or replacing the trach. Major bleeding is one of the most feared complications of a tracheostomy, and your differential is going to be based partly on timing. Early sources of bleeding include bleeding from the surgical site as well as suction trauma. These are usually venous and small volume. These can be managed with topical silver nitrate cautery as well as topical application of epinephrine or tranexamic acid. Late bleeding is bleeding that usually occurs 2 weeks or greater after the trach has been placed, and this has the potential to become life-threatening. Sources include granulation tissue as well as erosion into a major vessel. A tracheoinnominate fistula is usually due to vessel erosion from direct pressure from the distal tip of the tube or cuff against the innominate artery. Although this occurs in 1% of tracheostomies only, the mortality approaches nearly 100%. Nearly half will present with a sentinel bleed, and any hemoptysis exceeding 10 cc's or more really should be considered a sentinel arterial bleed until proven otherwise. Keep in mind you may not be able to diagnose the source of bleeding without directly visualizing with a fiber optic scope. So now that your patient is bleeding in front of you, what are your options? The first step should be to attempt to tamponade bleeding by overinflating the tracheostomy cuff, if there is one, or to insert a cuffed trach or a cuffed ET tube via oral intubation and overinflate the balloon. The recommended inflation is 10 to 35 cc's of air, and this should be sufficient in most cases. If that doesn't work, the next step is to insert your finger directly into the stoma and apply manual compression against the bleeding artery against the posterior sternum. Oral intubation is usually preferred in a situation like this. And please remember to call your consultants early, either ENT or cardiothoracic surgery, for operative management. Now what to do if your patient presents with a possible tracheostomy obstruction. The simplest approach is to remove and clean the inner cannula. If this isn't possible, you can apply humidified oxygen to loosen secretions and attempt passage of a suction catheter to remove those secretions. However, you may ultimately need to remove and replace the entire device if the obstruction persists. When suctioning your patient with a trach, place the patient with an optimal position with mild neck extension. Pre-oxygenate with humidified oxygen. Insert and advance your catheter no further than the distal tip of the tracheostomy tube to avoid damaging the mucosa, and apply suction while slowly removing the catheter. To round out your shift, you now see a patient who presents with a trach that was placed 3 weeks ago, which was accidentally dislodged while coughing. You evaluate the patient for possible tube dislodgement, including signs of respiratory distress, hypoxemia, agitation, subacute emphysema, or difficulty bagging if the patient is on a vent. If the tract is less than a week old, keep in mind the stoma can close rapidly and you may be left with oral intubation as your only option. And beware the patient with an obese neck, difficult anatomy, or a recently changed tube, as this may indicate a false passage has been created. If you're concerned about trach dislodgement, end-tidal carbon dioxide is a useful adjunct. Absence of a reliable waveform or an end-tidal less than 10 indicates that your tube may not be positioned appropriately in the airway. However, if your patient is not in distress, take your time with tube replacement. Gather all of your supplies at the bedside before proceeding. Keep in mind that a patient with a well-formed stoma and a mature tract may be able to breathe through the formed stoma without a tube for a short period of time. If you do need to replace your tube, you have several options. You can use the obturator that comes with most tracheostomy setups and simply replace the tube over the obturator. You can use a soft suction catheter to guide your placement, or you can use a fiber optic scope to directly visualize the tract into the trachea. So let's summarize. What will help you the most on your next shift when you see a patient with a potential tracheostomy emergency? Remember to take a focus history. When was the trach placed? Why does your patient have a trach? And what kind and size do they have? Gather all appropriate equipment at the bedside before proceeding with any procedures. Call your consultants early. Remember, the most common cause of life-threatening bleeding is a tracheoinnominate fistula. You can manage this by tamponading with overinflation of a balloon cuff on an ET tube or a tracheostomy, or you can insert your finger through the stoma and compress against the posterior sternum. You can manage obstruction with gentle suctioning or tube replacement. And remember 3 techniques for replacing a tracheostomy tube: over the obturator, using a suction catheter as your guide, or with direct visualization with a fiber optic scope. And with that, I thank you for listening, and I'll take any questions.